Hello, everyone. Welcome to Webinar Wednesday with Can Do Multiple Sclerosis. My name is Haley Van Wagenen, and I will be your moderator for today. Our topic is Overcoming Incontinence, Managing Bowel and Bladder Issues. I want to take a brief moment to thank our generous sponsors for supporting this year's webinar series. So thank you to EMD Serono, Genentech, Sanofi, Viatris, and Zenas Biopharma. I wanted to introduce our speakers for this evening. We are joined by physician assistant Lisa Fox and physical therapist Jessica Lupi, who specializes in pelvic health. So thank you guys for being here, and I will hand it over to Lisa.
Hello, everybody. So I really enjoyed looking at the chat thus far. I've counted about 15 different states and some Canadians. So welcome everybody to our webinar this evening. I always find it fascinating to see who's joining us. Oh, just somebody from Texas. Hello. I'm Lisa Fox. I'm a physician assistant over at Johns Hopkins Medical Center in Baltimore, Maryland. And tonight's going to be talking about some bowel and bladder issues. And any questions you may have, as we talked about, we'll have some Q&A at the very end of this. But if you have any questions in the meantime, put it in the chat and we'll put it all together so that we can give you as much information. I know there is questions sent to us during the pre-registration as well that we've kind of gone through. So hopefully we'll hit quite a few of those questions so we can have room for more questions at the very end. Okay, so the learning objectives today, we're going to be talking how to recognize bowel and bladder function and how they impact each other. And we're also going to be working on the understanding the role of pelvic floor physical therapy in bowel and bladder management. And Jessica will do a great job in that respect. And I think she'll answer a lot of questions that some of you may have and answer a lot of my questions. And I refer to pelvic floor therapists all the time, but here one-on-one with a therapist will be wonderful. And number 3, become familiar with strategies to manage everyday life. So let's go deeper into our MS bowel and bladder conversations. So before we start, we're going to kind of just do a quick overview of the central nervous system. Neurological condition that affects what we call the central. So we have the central and the peripheral. The central nervous system affects the brain, as you can see on my left, okay? Then it affects the cervical spine and the thoracic spine. The gentleman on my right in my pictorial here is what we call dermatomes. And the spinal cord comes out at each of these levels, the green being the cervical spine, again, going to the top little notch in the back of your neck, and then the thoracic is the blue. And MS can cause symptoms or lesions anywhere from the brain to the cervical to the thoracic. So in this picture, the brain, the green, and the blue. Now, the pathway of these nerves start off in the brain, and there's a tube they go through, which you guys know, called the spinal cord. And it's like a highway. If that highway is nice and smooth, then the path to the rest of the streets are going just fine. But if in your driving, all of a sudden there's a construction site or if there's a traffic jam, then the communication to down the road might be a little bit longer to get to. So it might take you longer, or you might never even get to that area, right? Same concept in central nervous system and our spinal cord from our brain. If you have a demyelinating lesion, and remember that's the coating on the nerve that comes disrupted and doesn't cause enough communication to the brain or the cervical or thoracic spine, then we can cause neurological symptoms. If you have a lesion in the brain, it affects the brain and everything below. If you have a lesion in the cervical spine, so let's say you have a lesion in the C6 area, you might have symptoms starting in the upper trapezius region and everything below. If you have a lesion in the T4 level, which is around the nipple level, it can cause symptoms from that level and down. So if you have a lesion at that level, you can have anything below. The lesions never go up. So we don't have retrograde, meaning back up to the head. We only have, we don't have antegrade. We only have retrograde going down. And guess what's down? The bowels and the bladder, right? So if you have a lesion in your brain, it affects everything below, potentially your bowels and bladder. If you have a lesion in your neck, potentially everything bowels and bladder. And the thoracic spine, bowels and bladder. What about that communication continues to have multiple lesions? Then that communication is even further reduced potentially, and you can have more bowel or bladder symptoms. So understanding why this may occur, even though MS doesn't affect the bowel bladder directly, it has an indirect effect because of the neurogenic, the nerve communications to it all. And that's important because some people are like, well, my bladder is not having a lesion, but the actual spinal cord communicating to it is affected. So next slide. So your symptoms. We know that treating MS is very, very important. Not only treating the MS progression, so the less number of lesions in our brain, cervical and thoracic spine, then less risk of neurological symptoms. But we are treating you guys as patients, right? Our goal as MS providers are to treat quality of life and improve your activities of daily living. So it's very important as providers for us to understand what these symptoms are. And every MS patient has a different disease course. We have relapsing MS, we have secondary progressive, and we have progressive MS. And they all have different kind of symptoms, and everybody's different. It's like a snowflake. Every MS patient has different presenting symptoms, different coping techniques, different struggles in life, different family support, but it's different. But the lesions can be the same, but they all can impair quality of life and how we make of it. So it's important for you to talk these symptoms with your providers. So we're going to go deeper into now what are the bowel and bladder symptoms that you might have heard of or you're experiencing specifically. So bladder dysfunction, it actually affects about 80% of people with MS. So 10 people in a room, 8 of patients with MS will have some sort of bladder dysfunction. And MS affects 2/3 females, right? And females in general might be like, I had a few kids, I might pee here and there because I had kids, right? But it actually might be the MS. Males, oh, my prostate might be a little enlarged, no big deal, but it actually might be the MS. So understanding other factors that can affect the bladder and the bowels, as we'll get to, really kind of play a role into all of it. But understanding that history and talking to your provider about your symptoms and the provider understanding you as a patient is very important. Bladder symptoms are one of the most underreported and therefore undertreated symptoms, okay? In the bladder dysfunction symptoms, some of our most common issues are what we call, fancy word for neurogenic detrusor overactivity. Neurogenic nerves. Detrusor is the muscle of the bladder that sometimes can contract really fast or it doesn't contract. And overactivity can become stimulated quite easily. And that's another word for NDO. If we don't treat bladder symptoms long term, it can really impair quality of life. And some patients do experience that pretty readily. Some people can manage them. It depends on your symptoms. But untreated symptoms can really lead to decreased quality of life and activities of daily living that become impaired. Urinary tract infections, UTIs. Urinary tract infections are not uncommon in MS, especially with some of the agents we use for treating MS. But just from the bladder symptoms, UTIs can become more commonly reported because the communication to that bladder might be spasming so much, but leave some of the urine in, or maybe it doesn't relax all the way and we leave some urine in. If you have urine in your bladder, guess what bacteria likes? Warm, moist environments. And guess what? Bacteria get in there, it replicates, and all of a sudden we have a UTI. Untreated UTIs can cause some symptoms in the bladder and the kidneys in themselves, so treating it very importantly. Urosepsis is the bacteria that goes from the bladder or the kidney areas into the bloodstream, and that can make you very, very sick and can lead to major issues. So untreated UTIs and urosepsis can come on pretty quickly, especially in the older individuals. And then we can also cause some issues with our upper urinary tract, causing some damage. Okay, next slide. What are some physiological implications of our bladder dysfunction? So the what ifs. What ifs are the worst, right? And they plague us. And if your brain gets so tired of the what ifs, then we might getting a little bit more tired. We might not go out as much. Our quality of life might get impaired. But how many of you that have MS have the fear of drinking liquids because you don't want to pee? You're like, oh, I don't want to go to my grandson's or my child's softball game because I'm afraid I might have to urinate in the middle of this very long 2-hour doubleheader, right? What if I don't want to go to the movies because I don't want to drink too much before I go out because I might have an accident? It's real. And I hear about it all the time as a provider. So that fear of drinking liquids, and if you don't drink enough fluids, and I'm not talking about like I'm talking about water and healthy fluids here, right? If you don't drink enough fluids, then the risk of dehydration increases. And if the risk of dehydration increases, then your healthy cells that are not affected from MS get tired because they're stressed, right? And if they're stressed, then your old MS symptoms become more notable, and then it's kind of a cycle. So hydration is so important. Then the next thing I hear, anxiety. What if, Lise, the anxiety, what if I actually have an accident? Or what if I leak a little bit of urine in my pad and I smell like urine for the rest of the day? These are all legit concerns, right? But talk to your provider because it's not unfounded. It's real. And the more we hear it and the more you treat it and improve quality of life, guess what? You're going to be more running. You're going to be going for it. So really working on those what ifs and telling your provider them will be very beneficial. Fear of leaving a vicinity of a bathroom. Let's say you're at work and it's all the way down the hall and you're like, oh my gosh, I have a meeting, but I don't want to be too far. Like that work component. These are all things we think about with our MS because it really impairs quality of life. But let's change it. Let's do well by you. If you have an accident, it's one of the most difficult things, especially if you have difficulty with walking, to have to change your underwear, change your clothing, change a Depends, change a pad. It's real and it's exhausting. And then not on top of it, you have to maybe sometimes ask for help. And that embarrassment is real too. So let's start working on understanding it better so we can really improve these. And I just mentioned the fatigue of changing everything. Yeah, somebody just mentioned, if I don't know where the bathroom is, I just don't go in because that what if, right? Those are true. And we will be getting to some avenues in terms of catheters as well. Next slide. So let's talk about what is the bladder. Here's a pictorial of a bladder, not my bladder, otherwise we'd have issues. Here's the detrusor muscle, the big kind of orangish red muscle that surrounds. And inside the muscle is where the urine is housed. And the bladder is this area that's all encompassing. The tubes that lead to that muscle are called the urethra, which connects up to your kidneys in that regard. And then down below is the sphincter, okay? And when the bladder gets full, the sphincter is closed, so it holds it tight. When you're ready to relax, the urethra opens from the sphincter, relaxes, and it kind of just goes out, okay? So this is a normal contracting bladder, but what if that communication is not fluid because of a central nervous system issue, MS? Then that bladder can do a couple of things. It can do spasms, or maybe it spasms or doesn't spasm, right? So it's a very interesting muscle that we really have to think about. And not only do we think about the muscle, we have to think about the sphincter. Next slide. Oh, I'll tell you what an SP tube is in a bit. That was a chat, by the way. So here are some bladder issues in MS. We have detrusor, remember that's the muscle, the detrusor overactivity, meaning it just becomes overactive, and detrusor underactivity. What if it doesn't work well enough? So if it works too well, then the storage problems. You're going too often. You might have some frequency where you go to the bathroom, you're like, crud, I have to go again. I just got up off the toilet. Not to hike back to the toilet area. Urgency, where all of a sudden you feel like the urge and then it leaks a little bit, right? Then what if we have emptying problems where the bladder doesn't relax all the way? Again, all nerve communication. We don't have complete emptying. We have frequency where we felt like you just went and it has to go again. Then I mentioned the sphincter. It's a fancy word for this part of it. Detrusor, the muscle, sphincter, the communication, dysnergia. It doesn't work well because of miscommunication from the nervous system. All three of those together can create one in its own entity or can come together in terms of a cascade of hesitancy, stream being interrupted, incomplete emptying, making the brain think different things, and it being very difficult on a quality of life activity on a daily basis. Next slide. So first and foremost, let's say when you get to your provider, you have to give a good history. Don't gloss over the bladder. Don't gloss over the bowels because it's legit. Get a good history. Are you able to walk? What are your limitations? Are you having bladder issues? Are you spasming in your bowels and bladder? Are you spasming in your balance? What is going on from head to toe? Because guess what? It's all connected. Sexual symptoms, bring them up. I know it's embarrassing. Close your eyes and talk to your provider. But sexual symptoms can be correlated kind of with the intensity of bowels and bladder. And guess what? Sexual symptoms when having intercourse can cause bladder issues too. So we want that part of life to be real. We don't want that to be avoided because you might have concerns about leaking in the urine department with sexual intercourse. Bladder symptoms, we just talked about many of them. Lisa, when I gotta go, I gotta go. Lisa, I feel like I have to go. I pee and then I gotta go again. Oh my gosh, Lisa, I wake up 3 or 4 times at night just to go to the bathroom. How often do you say that to your provider, or how often do you feel that? Inability to go, or all of a sudden you go, so all of incontinence is the leakage part of it, and it impacts the quality of life. Urinary tract infections are very important. We need to treat UTIs. Untreated UTIs can lead to infections in the blood and urosepsis, and it can lead to kidney infections. So we definitely need to treat UTIs. So I know one of the pre-questions are what are some things that can trigger bladder spasms? Caffeine, alcohol, tobacco, things along those lines and spicy foods can trigger bladder spasms. So think about that. Maybe drink fluids, but if you're about to have a coffee in the morning because you're fatigued, think about maybe I'll be near the bathroom during that time. So those are things that trigger bladder spasms. And when the bladder spasms, you have to pee more frequently. If you overdo the fluids, timing on fluids, and we'll talk about some avenues how to help with that. Physical barriers, think about the steps. How many steps do you have your house? Is your bathroom on the first floor, second floor? Where is the bathroom at work? These are all things. Lighting, waking up in the middle of the night. Do you have a night light to prevent falls? Can you get to the bathroom? Okay, next one. So how do we know if you're having bladder issues, or maybe you're not having bladder issues from MS? Maybe you're having bladder issues from something else. That is something that needs to be ruled out. We can't always assume MS, every MS patient with bladder issues is MS related. Factors outside of that need to be considered. Kidney stones, prostate in males for sure. We have to think about, is there other factors? Is something going on the uterus causing some pressure? What's going on in the bowels? These are conversations that we need to have because you don't always assume MS and bladder are truly related. A lot of the time they are, but we have to rule out other factors to make sure there's nothing else going on. So some ways to do that: post-void residual, that tells us how much after you pee, how much urine is left in the bladder. And that's very beneficial for urologists to really understand if there's further testing that is needed. Always rule out a UTI. Any patient that comes in and tells me, hey, Lisa, I'm having increased urinary urgency, I'm having some more accidents, and I haven't had them recently, you think first and foremost urinary tract infection. UTIs in my MS patients are not as, they don't have the common pain. They don't have the blood in the urine. It's more silent, quiet, and usually my MS patients are having worsening MS symptoms because their body's trying to fight the infection, but it's really their bladder having a UTI, not your MS worsening, it's the UTI. So always have a urinalysis checked if you think you're having worsening urinary symptoms to rule out a UTI. A urodynamic scan or urodynamic testing is another way to look at how well the urinary tract can store and release. If you see a urologist, a cystoscopy, a procedure that can look inside to make sure there's not a blockage in the urethra or not a blockage in the bladder or other factors going on in the bladder. Sometimes we need to do pelvic ultrasound to make sure there's no masses in the bladder as well. And again, as I said, for the male's prostate, they can be very tricky sometimes to figure out is it prostate or is it MS. If, when in doubt, if you're having recurrent UTIs, you're having quality of life issues, they're interfering with activities of daily life, urologists are amazing. I encourage anybody with bladder symptoms, even though I treat MS directly and solely, to have a urologist on hand because they are so knowledgeable. They can rule out these other factors more than a neurologist can do. So seeing a urologist can definitely be highly beneficial and improve quality of life. We also have to think about medications you're taking too in terms of UTIs. I just wanted to throw that out there. Okay, next question. What are some medications? Okay, so we talked about the neurogenic detrusor overactivity, NDO, right? There are quite a few bladder medications that can help with the spasming and the relaxing of the bladder. So many to the point that we have quite a few, and I'll list them on the next. They definitely can be beneficial, but side effect profile may be a problem. So you have to think about what's the best medicine for you. My rule of thumb is if you're not having urinary tract infections, and if your bladder symptoms are starting to impair your quality of life and you're limiting activities of daily living, such as going out, not going out with your husband, not going out with your wife, family members, etc., then by all means, you should think about a bladder medication, as long as you've ruled out other factors outside the MS, okay? Symptoms of overactive bladder can be used definitely for bladder medications. A low post-void residual, less than 200, meaning after you urinate, you still have a low post-void residual. No UTI. There's no reason to treat with medications if you're having recurrent urinary tract infections because we're not treating the correct cause. Pelvic floor physical therapy, as we'll be talking with Miss Jessica Lupi. She's a pelvic floor specialist, so she'll be going into depth about that. It is awesome. Patients really can respond. It's along those lines. So if you haven't tried pelvic floor and have bladder issues, it is a great physical therapy program for the bladder. Other interventions are called transcutaneous posterior tibial nerve stimulation. Fancy word for, it's a stimulation for the bladder from a different part of the body. Botox, if your bladder is spasming all the time and it's not able to relax, Botox has been proven to be very beneficial along those lines. And another kind of modulation, like a stimulation, is called a sacral neuromodulation that can be used. And again, the urologist can further discuss that in that regard. So we're going to talk about, this is a large slide, a lot of information on it. This should all come from your urologist or your provider in MS. But here's a cascade list of medications that one can use. And each of them have different kind of mechanisms of action. There's two different types of classes. But one of them, called oxybutynin, is a common one that's kind of old. And what it does is it relaxes. And biggest side effect is that we see that it can cause some dry mouth in that regard. Other medications called Detrol, Vesicare, also, and Enablex, we don't use as often, but is still used, can similar dry us out. Okay, when we get dried out a little bit, then it can cause side effects of like dehydration, constipation. So you really need to know if it works. Now, these are side effects. These do not happen in every individual. Okay, so you definitely, I say, go low and slow to see how you do. Some of the older agents we have used in the past. Flomax is used also for people with prostate issues. Mirabetrix and Gemtasa are some of the newer agents. They tend to have less side effects in terms of the dry mouth, and they tend to have a little bit less side effects and cognitive changes. So if you read up on the PI of each of these, you will see it, but they are highly beneficial. Go low, go slow, because it may benefit you. If one doesn't help you, doesn't mean the other one's not going to help you. So definitely talk to your urologist and your MS provider, because there are some avenues and there's a multitude of medications. Next one. So other interventions in bladder management that we've talked about, intermittent catheterization. So that is sometimes many different ways we can do catheterization, but some people can have a straight cath and they can just do it right before they go on a car ride for a long time. Some people use intermittent catheterization before they go out to the movies, go out to dinner, and it helps relieve that urgency and the filling up as much so that you don't have as many quality of life concerns during the next few hours to help you out. Medications, as I just mentioned, there are two other stimulants, the sacral neuromodulation and the PTNS. What they do is they stimulate the spinal cord in different avenues to help relax the bladder or stimulate the bladder appropriately to help in terms of your bladder spasms and urgencies. And Botox, if the bladder spasming, just like if you have difficulties with contractures in your arms or your legs, Botox relaxes it. Same concept with the bladder. And it works really well. Again, side effects, you have to be careful it doesn't relax it too much and then allow the urine to residual in there and causing UTIs. But your urologist or the person administering the Botox is very well, and they usually start off with lower doses to see how it helps you before you just jump into a full dose and have major side effects. There are other catheterizations I want to mention. There's different types of catheterizations. There's a suprapubic catheter, which is a bit more invasive, but again, it comes down to quality of life. And that reroutes kind of the urinary tract a little bit into the pubic area. And then you're able to have a bag in that regard, and it reduces the risk of having accidents, urgencies, and improves quality of life, especially if you have mobility issues. Again, it comes down to conversations with your urologist and your neuro team. There's different types of catheters. Sometimes we have catheters that we can put around right around the penis, like a condom catheter that allows just an easy hookup, but there's a risk of it falling off. But everybody manages and copes well with it differently. But if you have, there are a couple other catheters that are very different that one can use to help improve some of the incontinence and the urgency symptoms. Okay, next slide. So now let's divert to bowel dysfunction. So just like bladder, it's a communication to that part of the nervous system and the dysregulation and to the bowel component. So it's the nerves not allowing the bowels to get the communication well. And with this, it can become constipation. We can get some urgency. We can get abdominal pain. And it's never fun to have a bowel movement unpredictable, right? Even if you don't have MS, everybody can understand that. With MS, if you're having severe constipation and the pain, or when then you have the urgency and you go back and forth from bowel to bowel urgency to constipation, these are all things that MS can do. If we do have bowel incontinence, or maybe we don't have full emptying and leaking, all part of MS, and these are conversations, don't ignore it. Don't just think your diet is a part of this. This can be MS. Now, diet can help it. Diet can worsen it. So please have conversations. Dehydration is a part of the bowels as well. In MS patients, we're more prone to having dehydration, especially if you're on some medications, which then can slow down the gut a little bit more and cause increased symptoms. So please have those conversations with your team. Anorectal dysnergia, meaning the sphincter and the communication between your anus and your rectum is not working well because of neurostimulation disorders, which can also cause bowel issues. So having conversations around that can definitely help quality of life. Now, those are all big words, all lots of what ifs in that respect, right? What is this? What is that? Bowel issues, diarrhea, constipation, pain. The best treatment is exercise and making sure you're drinking well. If you're drinking enough fluids, constipation significantly improves. If you're eating low processed diet, meaning not going to fast foods, not doing a lot of fried foods, eating a balanced diet, your bowels in itself are going to be that much more smooth. But if you're not, it adds to it, right? Exercise. Exercise stimulates the bowels in a very healthy manner, keeps that communication going on from your brain and your spinal cord to the gut, and it really can improve quality of life symptoms and gut dysfunction. If you're having some constipation, the gut goes down, like the tummy goes into the colon and it turns to the left. So palpating and massage, laying on your left side can also help gut mobility in that respect. And that is a nice thing to do just from a daily basis with the constipation. Physical activity, as I said, is important in that respect. Next slides. Treatments for bowel dysfunction, as I mentioned, fluids. Some people feel that if they're having constipations, adding fiber to your diet may be kind of deleterious. Actually, increasing fiber bulks up the stools to help it move through and the gut motility better, and that can help. Exercise, as I just said, some people find different juices beneficial. Some people find other avenues, very holistic approaches. Whatever works for you in the holistic approach, I encourage. As I just mentioned, gut massage. Stool softeners are very important. If you're having such significant constipation, stool softeners, there are some medications like Linzess that help gut motility, can be very beneficial. Some of my bladder medications can also help the gut motility. So talk to your specialist in that respect. Now, enemas. Remember the sphincter controls, just like it does in the bladder, the sphincter of the anus controls the release of the bowels. If we have dysregulation from our MS in the sphincter, that's one thing. But enemas can paralyze the sphincter by not letting it use as much. So be very cognizant on enema use. If you're using enemas too frequently, please, that might be more deleterious, so talk to your provider in that respect. Toilet posture is also a very great activities of daily living, healthy approach. Elevating your feet to tilt your pelvic floor back a little bit, and Jessica will be talking about that, can help with the evacuation of bowels as well. And there are some other avenues called biofeedback to help the gut and the communication to your gut get a little bit smoother. Just like anything, exercise to the gut and the bowels and bladder are very beneficial. And I think I'm about to turn it over to Jessica But before I do that, I want to mention one thing. It's summertime. It's starting to get hot. If you're in Arizona, it's like 100 degrees already, right? Utof's phenomenon. When your nerves get overheated from going into humidity, the heat all of a sudden going from air conditioning to the heat, or if you exercise too suddenly, the actual nerves get heated a little bit, not directly, but indirectly. And when that happens, that communication across the nerve becomes a little bit slower. And if that communication across the nerve becomes a little slower, then the communications to the rest of the body. So this Utof's phenomenon, where your body gets overly heated and old MS symptoms can flare, that is also can affect the bowels and bladder. So keep that in mind with the summer months. Keep cooling towels in your car if you're about to go from air conditioning to the heat humidity all of a sudden. Put towels under your armpits if you're going to the beach. Get an ice cold bucket of water and have your family members put more water in and keep it cold to keep your core temperature down to improve the quality of life for your gut and your bowels, as well as your bladder. Okay. Jessica, I'm going to turn it over to you.
Okay, thank you, Lisa. That was a lot of absolutely excellent info. So, what I am here to talk about, I am a pelvic floor physical therapist. And so I am going to talk about more of the musculoskeletal component of bowel and bladder and how those things kind of tie together. So I kind of wanted to first look at anatomy so that we kind of understand the major players and where they are in relation to each other. So if you look at the left side of your screen, we have a diagram of a male where we're looking at kind of how bowel and bladder live very close to one another. And just due to their physical proximity with one another, they can relate symptom-wise. So if you look from kind of the left to the right, we have the penis, which houses the urethra. We have the testicles. We have that little gray blob that represents the pubic bone, which is a bony border. We have the bladder, underneath that, the prostate. We have the bowel directly behind that. And then we have the spine, which is another bony border. So when we go about our day, our body is constantly producing both urine and fecal waste, just as it metabolizes different things in our body. And so both of those organs are really neat because they are storage devices. And so as they fill, they take up more space. You see that the pubic bone and the spine are both bony borders. So you only have a very limited amount of space in this pelvic cavity. And the more the more urine that's in your bladder, the more poop that's in your bowels will take up more space within this tube. For the female diagram, we also have that uterus in there. And so a lot of times people come in and they do okay, and then they're on their period and uterus is a little bit enlarged, and that really makes their symptoms worse. So just the sheer proximity of these organs will definitely make them impact each other. Lisa was giving us a good definition of that neurogenic detrusor overactivity, how it can get stimulated quite easily and kind of give you contractions of your bladder when you don't really want them. Being constipated can be one of those things. So your bladder issues might be coming from your bowel, sort of related to MS, sort of not, in the terms of they just impact each other. They're so closely related, there's really hard to separate them out from one another. So the next thing we're going to look at is the pelvic floor itself. So if we can flip to the next slide, we're going to take a look at the actual pelvic floor. So a lot of times people refer to the pelvic floor as it's one unit, but it's actually 16 different muscles that make up this really complex hammock of muscles that support our body in a couple different ways. So the pelvic floor is a group of muscles that lives at the base of our bodies, and it helps control bowel function, bladder function, sexual function, a little bit of posture, a little bit of breathing, and a lot of organ support. And so the pelvic floor needs to be able, this group of 16 muscles needs to be able to coordinate with each other to either squeeze and hold up our organs, hold in our pee, poop, and gas when it's appropriate, or relax and get out of the way so that we can properly evacuate our bowels or bladder or have sex without pain. And so, as you can see on this diagram, it's not just one muscle that's kind of like surrounding the urethra or surrounding the rectum. So if we look kind of at the base, so where you see that point down, that is your kind of your tailbone. And then right in front of this is a female diagram. That would be your rectum. In front of that would be your vagina. And then closest to the bottom would be your urethra. And so there's not one muscle that controls each of those holes. It's kind of this whole unit that all kind of has to work together. And so we're going to kind of chat about how you can use this muscle group to kind of impact your symptoms. And yes, your symptoms might be coming from MS, or as Lisa said, they might be coming from something else, or you might have a little bit of both. And so my job as a pelvic floor physical therapist is to say, okay, this is where we're at coming in. What kind of things can we modify or change or get you better at so that the symptoms themselves go away? I'm not going to be doing anything to change your MS, but we can change the presentation of things that are going along and change your quality of life. And that's literally my only goal, is to make your life a lot easier. So let's go on to the next slide for me. Okay, so if we think about urinary incontinence, constipation, urinary retention, and fecal incontinence, they all have one thing in common. It's the thing you want to happen is not the thing that's happening. And so it's not a game of, oh, well, if you just, tried a little harder, it would work for you. That's not the case. So we're going to kind of chat about what kind of things can contribute to giving you better control, that we're not going to be modifying your MS. We're going to be modifying all sorts of different factors that can help or play into this. So if we look at the next slide. So as a physical therapist, we have a ton of stuff that we can look at to kind of impact bowel and bladder. So your pelvic floor is very uniquely situated where it is attached onto your pelvis. Your pelvis is located smack in the middle of your body. And so your abdomen attaches there, your glutes attach there, your back attaches there. We have all of these other muscle groups that are coming in and directly or indirectly affecting how the pelvic floor is working, which is going to directly affect how your bowels and bladder are able to work. So some of the things that pelvic floor physical therapists look at, or physical therapists in general, we're going to look at your range of motion. So range of motion of your pelvic floor. Can you squeeze it? Does it move up well? Can you relax it? Does it move down well? Both of those are very important. Your general mobility. How do you move around? Are you able to squat low enough to get on the toilet so that you can get your pelvic floor in a nice position to fully evacuate? Or is that not possible? Do we need to kind of make some modifications to your bathroom setup? Your strength. It takes some abdominal strength to push out poop, to push out pee, to hold poop and pee in. That is all very important stuff. Your nerve function. Okay, is this truly an MS thing? Is it delayed? Do you have altered sensation? Do you have delayed kind of, okay, I tell you to squeeze and you can get there eventually, or I tell you to relax and it's coming, it's just a little delayed. Looking at balance. Balance is a huge piece of what I do. Honestly, I swear I work more on feet and balance than I do pelvic floor some of the time. Looking at your gait. How are you able to walk to the bathroom? If you get the urge to pee and it's coming quick, are you able to get there fast enough so that we can get to the toilet and avoid having either urinary or fecal incontinence, or do we need to work on that? Breathing. Breathing is a huge one. So your pelvic floor lives at the base of your body and your diaphragm lives at the top. And they should, in a nice little healthy system, work as a little piston. And so breathing is an excellent way to kind of tap into that pelvic floor. Let's say you don't have the best control. Breathing is a great way that we can kind of cheat the system a little bit and get us some extra wiggle room with some of the urge stuff. And we'll talk about some of that with urge suppression and things along those lines. Body mechanics. When you're sitting around walking, doing your work, doing whatever you do, how is your body positioned? Is it in a spot where you're kind of maximizing the way in the place that your pelvic floor wants to be working? Or do you have terrible posture and you're really making your pelvic floor work 4 times as hard as it really needs to kind of do its regular job? Healthful behaviors. Lisa talked a lot about this, and that was excellent. Of all the different foods and beverages that we consume, definitely play a big role. Exercise, all of that jazz. We want to kind of look at, where are you at in life right now? Where do we want to go? Where do we need to go? Motor control. Can your body do what you tell it to? I don't know. Let's find out. Coordination, kind of same thing. Kind of how well are you able to coordinate different body parts? Of pooping is kind of a complex activity if you really think about it. Can you control your sphincter? Can you control your pressure? Can you hold a position for a long enough time? And then just your overall health habits. Like what does health look like to you, and what do your habits and how do they kind of kind of contribute to the symptoms that you're having, and what can we change and what can we modify. So if we look at the next slide. Okay, so physical therapy. What does all of that actually mean? What does that look like? So we as therapists kind of pull tools from 4 major buckets. We can do modalities, manual therapy, exercise, and education. So modalities, that's just kind of a fancy word for other things other than our hands or your hands doing something to your body. So Lisa had mentioned biofeedback. One of my favorite modalities is a form of biofeedback called balloon training. And so this is excellent to kind of, okay, so let's say you have fecal urgency and you're not able to, your rectum, when you get some stretch in your rectum, it's just reflexive. You are having a bowel movement. We can use something like a ballooned catheter to train your body to accommodate more stretch comfortably and teach you urge suppression techniques to do as your body learns to accommodate the stretch and stops getting so hyperreactive. That's a huge one that's super helpful. Biofeedback is really helpful. Sometimes a finger inserted into either rectum or vagina and kind of telling you, hey, when you do this, this is what's happening at the muscles. This is what's happening at the sphincters. What does that feel like to you? You're not sure? Great. Where else in the body can we find something that we can kind of tap into? Oh, okay, I know that when I feel that pressure in my abdomen, that's urge. I've actually felt that for the last half hour. I didn't know that's what that was. Great. That's a great time to go pee so that we're not letting things build up to the point where they're just totally dumping on us and we are not in control. Manual therapy is kind of what it sounds like, using hands or stretching, doing kind of range of motion stuff. A lot of times it's helpful if people have hypertonic pelvic floors that are really tight. And so they have a hard time relaxing to let things out. Or if they're kind of baseline really tight and now we have a lot of urine in the system and we have to hold that up, they don't have anywhere else to go. And so they have a hard time squeezing further and they can't hold their pee in. Either way, manual therapy is a great way to do it. If you think about having like a tight muscle in your neck, massaging it helps get the tension out. Same thing with pelvic floor. Therapeutic exercise is what it sounds like. Any kind of exercise that would be helpful for you in your particular situation to help us achieve a goal. So if that's, we're constipated and we need some big rhythmic movements, great. We can't walk right now. Okay, that's great. We're going to sit in a rocking chair and we are going to get that nice big rhythmic movement in a rocking chair to help stimulate our bowels so that we can have better bowel movements. Love it. Therapeutic exercise counts. Patient education, talking to you about your specific scenario and kind of figuring out where you are, what we need to do, different resources that might be helpful for you, the different kind of people you need on your team. If you come to me and you have an MS and all you have is a neurologist or all you have is a primary care provider and you have bowel or bladder symptoms, my butt is sending you to a urologist, sending you to a GI, making sure you have a good neurologist on your team because you need a good team and a good foundation to kind of help manage all of this. So if we look at the next slide, we're going to talk about some strategies that we can use to kind of help manage everyday life. So let's say someone is having some urinary incontinence and you're the kind of person that you're going about your day, you don't know it's coming, and then all of a sudden you're in the middle of doing something and boom, you just get hit with your entire bladder just does its thing and you had no idea it was even coming. So something that we can do is something called timed voiding, where we kind of set a timer and say, okay, great, you're going to pee every 2 hours on the dot so that we don't let that bladder get so stretched out before we realize what's going on. Another thing is for someone who has a lot of urgency where they feel like they have to pee every 15 minutes and they're like, I literally just peed, nothing even comes out. And we've ruled out a UTI, we've ruled out anything kind of nefarious. Time voiding is a great thing. And we're going to kind of use some of the urge suppression techniques that we're going to talk about next to increase our voiding interval. So maybe we start at 15 minutes and we're like, great, you know what? Go pee every 15 minutes. Sure. We're going to start pushing that to every 20 minutes, every 30 minutes, every 45, every hour, so to get you to a more normal voiding window that works for your life. Same thing with bowel movements. We can work on that with time voiding. Okay, let's say you have a bowel movement. around like in the afternoons and you just can't, you don't know what's coming, you can't get there in time, amazing. We're going to start building a bowel routine for you where we can get you on more of a time schedule. And so we can preemptively kind of deal with some of those issues. So urge suppression techniques. These are some of my favorite because they are so easy to implement and they make a really big difference in people's lives. So Lisa was kind of telling us about how that brain and spinal cord is kind of like a highway. So one of my favorite little fun facts is that your calf muscle, your gastrocnemius, and your bladder take the same highway back to the brain. They take that S1 nerve root. And so a really helpful urge suppressant technique is, okay, I have to pee. I know I just peed 15 minutes ago. It is not a real urge to pee. If you stand up and you do some calf raises where you're lifting your heel off the ground and popping up onto your toe, as long as your balance allows you to do, and just kind of you spam that nerve root channel with calf raise, calf raise, calf raise, and you do about 10 of those, that can help quell urge to go pee. Like it's really helpful for urinary urgency. Another thing that can be helpful, a lot of times, so normally our bladder fills to about 40% full, and our brain should get a signal saying, hey, bladder's about 40% full. Find a bathroom in the next 30 minutes, just kind of keep an eye out for one. And then it fills to about 60%. And then your brain should say, hey, kind of gotta pee. Let's finish up what we're doing in the next 10 minutes. Let's go pee. Then if we let it get to 80%, it is sending you those like urgent pain, get to the bathroom right now, you got to go signals. A lot of times with a history of urinary incontinence or fecal incontinence, that alarm system gets very much sensitized. And so what feels like, holy cow, this is a 5 alarm fire, we have to go really badly right now, is actually only 20% full or 60% full. That alarm level has just gotten a little bit more sensitive. And so sometimes just taking your brain and taking its mind off the task, like having you play a phone game like Candy Crush, Tetris, I don't know, whatever your phone game of choice is, just to mentally distract yourself for a good 5 minutes, that can sometimes help that urge go away too. So other things that can be helpful is directly using the muscles. So if you have good muscular control and good strength, sometimes squeezing your pelvic floor muscles and kind of reminding your brain, hey, we're squeezing right now, we're working, we're doing something. This is not a good time to send us the urinary signal. That can be really helpful to kind of mitigate that urgency. And then other times, if you're a person who has higher tone pelvic floor, honestly, relaxing it a little bit, giving that bladder a little bit more space can be really helpful by kind of taking some deep breaths. And I call it butt breathing, but breathing down into your pelvic floor and kind of getting that length there can be super, super helpful. Other strategies that we have, if we go to the next slide, are talking about your bathroom setup. So let's say Lisa had kind of mentioned this as far as toileting posture goes, but okay, so we get into the bathroom. Are we able to actually get onto the toilet easily, or does it take us a minute because it's really hard to get down there, or we need something like a seat riser to kind of bring the toilet to us instead of having us go all the way down to the toilet. Something like grab bars. If you have bad balance, it's kind of hard to do a sit to stand on the toilet with no hands. Sometimes just having some grab bars to help ease you down is really helpful. Also, night lights are really helpful just to kind of install in the bathroom so that you can see where you're going. And then other things like squatty potties and things like that to kind of help force relax your pelvic floor can be super, super effective. Exercising and stretching. So like Lisa said, sometimes bowel and bladder stuff is due to MS. Sometimes it's just due to whatever other life circumstance and musculoskeletal situation you got going on. And so if you have underlying pelvic floor issues, we can do a whole lot with that and kind of get those out of the way and see what we're left with as far as bowel and bladder things go and kind of go from there. And then a lot of times, sometimes we just need a good product that will help us kind of feel more confident so that we can utilize some of these strategies because they're not going to be perfect right off the bat. And a lot of times it's helpful for us to have something as like a safety blanket to kind of rely on until we get where we want to be. So some of my patients' favorite things are for men, penile clamps, just to kind of prevent any urinary incontinence, so they can feel like they can still be hydrated, so they can go out to that baseball game. They know they have a physical barrier kind of stopping the pee from coming out. And then it also can kind of help with time voiding of like, okay, I'm trying to train my bladder to hold a little bit longer. Great. I'm going to clamp off the end and I'm going to go to the bathroom every hour so that I have this kind of retraining mechanism. For fecal incontinence, there's something called B-sure pads that kind of just tuck up and into that rectal area. And so you can just walk around and you don't have anything in your underwear. It's just this very little discreet pad. And that's great for people who have like more fecal leakage or fecal smearing that they just need a little bit of something. Period underwear. It's great for urinary incontinence. It is not just for periods. It is super helpful just to give you an extra little barrier and protection. People use pads with period underwear just to kind of get some more absorption, and so that they know they're safe and they can go out about their day and they don't have to worry about it. And then I know a lot of people are concerned about the smell of either fecal or urinary stuff in their pads. Sometimes charcoal liners can be really helpful just because it kind of mitigates that smell while you're wearing it. So you don't have to be super self-conscious of, oh no, I just felt a leak. I don't want to walk around like this for the next 2 hours, but there's not a bathroom that I can change, yada, yada. Have a charcoal liner. You're good to go. No one can smell it. I promise. So, those are some things that pelvic floor, those are just some of the things that pelvic floor, the physical therapy will talk to you about. Every single person, like Lisa said, is kind of like a snowflake. No two sessions look alike for somebody. There is no protocol. It is just kind of, you show up with where you're at. We problem solve it together. We try to figure it out. I'll give you my best. You give me your best. And we're in it together. It's a physical therapist is just a teammate to kind of go on this journey with you together. I always say, like, yes, physical therapy, physical, yes, but therapy is a big piece of it. I am lucky enough that I get an hour with my patients. Oh, we get to know each other. And so having someone to just bounce ideas off of and be like, hey, try it. Okay, yeah, that's not weird. That's not crazy. You're not losing your mind. You want to have sex with your husband, but you're afraid to pee on him. Great. Try it in the shower. I bet he won't care. And things like that are really, really helpful just to have another support person on your team while we figure out what we can do to actually modify the musculoskeletal system to make your quality of life better. So that's kind of the role of pelvic floor physical therapy in MS and treating bowel and bladder dysfunction. So I think we are going to turn it back over to Haley, and she's going to take us through some questions.
Yes, we have now gotten to our question and answer portion of the webinar for tonight. And so with that, we did get some questions prior to the webinar, and I've pulled some questions throughout the webinar. So I will go ahead and get started. The first few questions are for you, Jessica, and they're kind of paired together. But how would somebody find a pelvic floor specialist that is near them?
Okay, so I always recommend kind of just going to Google, and there are a couple really excellent trusted websites. So the first one would be the Academy of Pelvic Health Physical Therapy, and they have a PT locator. So this will take you to practitioners that are specially trained in pelvic floor physical therapy. Another great website is pelvicrehab.com, their pelvic floor locator, or pelvic floor physical therapist locator. And that will also take you to physical therapists that have been trained in true pelvic floor physical therapy.
Awesome. And with that, I will link that as well on the recording that will go out. So it will be available for everyone to find those. You don't need to rush and write them down. And then as well, do most physical therapy clinics have a pelvic floor specialist?
Ask me again in 10 years and the answer will be yes. But for now, probably not. I would say it's expanding for sure. But I would always just call and ask the physical therapy office. And the most important question to ask is, does that pelvic floor physical therapist do internal work? If the answer is yes, they are the person for you. If the answer is no, hang up.
Perfect. And going off of that internal work as well, a few people had mentioned that it kind of sounds scary for an initial visit and like thinking of different things that pelvic floor specialists do. What should someone expect in their first initial session?
Yeah. So honestly, the first initial session is kind of a get to know ya. And so a lot of times, oftentimes, the first 20, 30 minutes is just talking. We are just chatting about your bowel function, bladder function, sexual function, posture, breathing, orthopedic issues. And oftentimes, most people don't even know that an internal is a thing that physical therapists do. And so I usually let people know at the first visit of like, hey, this is something that would give us a lot of great information. A lot of times people have trauma, people have whatever they're bringing to the table, and they don't like to be surprised with that when they don't expect that. And so I always tell them, hey, we don't have to do it today. We don't have to do it ever if you do not want to. And every physical therapist, they are going to respect that. No one is going to make you do something you are uncomfortable with. And so most of the time it's just talking. We have so much stuff to look at orthopedically. We are not worried about your pelvic floor on the first date. Don't worry about it.
Perfect. I hope that will help some clarifying for people. And I think too, when calling, now they know what to ask as well. Another question we have are what are top 5 foods that you should avoid with bowel and bladder problems?
So we can tag team, but alcohol is bladder spasm. So is caffeine. Okay. Spicy foods can trigger definitely some bladder issues. Tobacco, it's not a food, but it's a huge irritant for everything. And those are the 4 I say. Jessica, do you have a 5th for 5? I mean,
I was
those
gonna
are the,
say sometimes carbonated things can
yeah.
irk bladder, but yeah, I think those are the big 4.
Great. Thank you, guys. We will ask one more question. This is kind of a double question. Besides medications, is there anything to help control urgency? And as a provider, how do you feel about somebody using a medication like Imodium to take their fear out of bowel problems for travel?
Quality of life, right? So we want, at least I really encourage all our MS patients to complete everything they want to do in their life. Don't let their MS symptoms stop them. Their pathway may not be the same from 10 years ago from here to here. It might be up and down a little bit, but you can still get to where you go. Imodium as needed, no problems, okay? If you take it regularly, that can cause the problems, but as needed to get through quality of life, no problems in that respect. And the first part of that question, cognitive fatigue later in the
Um,
day for Lisa
yes,
Fox.
anything to help control urgency.
Oh, so I think Jessica talked about it. Just plan for it. Like if you have to urinate, do a scheduled breaks. You hydrate. I saw in the chat some people are like pee and then go to the bathroom. Some people like drink it all at once and then just get it done with and then be free. It really depends on you. But knowing your bladder, knowing where you are in your life in terms of what you're about to do, breaks are appropriate. Know what stimulates your bladder. Medications are very beneficial. I saw in the questions in the chats a lot of people are like, this medication works for me. I did Botox for this long. I did medications for this long. Cognitive concerns. It has to be right for you. So whatever you're choosing, if something stops working, it doesn't mean it's not going to work again a year later. You can switch things up. But keep doing the holistic approaches to all of this as well. Keep your bladder strong. Keep the communication, exercise, hydration, healthy eating.
Awesome.
And also for the urgency piece for fecal urgency, I feel like I don't have like a great immediate like, oh, actually, you know what I do? So there is this cool little reflex called the rare reflex. And so if you have fecal urgency, so normally your internal anal sphincter has these special cells inside of it called sampling cells. And so normally our body kind of like shoots our poop down the tube a little bit further into this sample cell range. And then it gets a sample that says, okay, is this solid, liquid, gas? And then it kind of scooches it back upwards into the rectum for storage. Your body does that all the time to kind of figure out what's in there. You can kind of tap into that reflex when you have fecal urgency by taking your external anal sphincter, the butthole muscle that you can control, and squeezing it for about 60 to 90 seconds. And that will help generate that reverse peristalsis at the like internal anal sphincter and rectum to kind of hang in there a little bit more. And that sometimes can help decrease for fecal urgency.
Same thing with urinary urgency, Kegel exercises. Yes, you might pee initially when you do them because you're tightening everything. So be ready for a pad, but ultimately it improves it.
Awesome. Good to know. This was so educational. I know I learned a lot, and I saw in the chat that everybody is learning a lot as well and has enjoyed this webinar. I do have a couple more slides just to go through, but thank you all for joining us today. The webinar has come to an end, but we hope you stay connected with us. Please follow us on social media for the latest programs, resources, and MS news. You can register for our monthly e-news series by going to cando-ms.org, and you'll get our monthly updates. With that, I do want to thank our sponsors one more time for supporting this year's webinar. Thank you to EMD Serono, Genentech, Sanofi, Viatris, and Zenas Biopharma. So thank you guys so much for being here. Thank you to Jessica and Lisa for being here as well and giving us all of your knowledge, and we appreciate it. So thank you guys all for being here. Hopefully we will see you next month.